So we're learning more and more about BPDCN every day and learning more about how we can harness new drugs and existing drugs to treat this disease. So one medication that is being used in many different types of blood cancers, a drug called venetoclax, which works as an inhibitor of a protein called BCL2. This has been investigated for several years now in BPDCN and does appear to have activity both as a monotherapy, just given alone, and in combination with some other agents, some of which we're very accustomed to using in other types of leukemia. This is a pill, so it's actually very, very easy to administer. Patients are, the side effect profile is fairly tolerable. It can drop some of the blood counts, but it is overall a very tolerable therapy that doesn't have any of the really life-threatening side effects that a drug called like tagraxofusp has. And so we're learning about whether and how we can harness this particular drug in our BPDCN treatments. And then there are other attempts to target this fact that the BPDCN cells express this protein CD123 on the surface by creating newer drugs and other types of immune therapies for BPDCN. So one example of this is a drug called PVEK that is in the later stages of development. So like tagraxofusp, it's an immune therapy that binds CD123. And it's a type of therapy that's called an antibody drug conjugate. So this little Y-shaped thing is an antibody. It's a protein that targets the cells and it binds to CD123. And attached to the antibody is a novel anti-cancer drug. So the antibody binds to the cell at that CD123 protein. It gets integrated into the inside of the cell. And then once it's there, the antibody portion degrades, but that chemotherapy payload gets released and then integrated into the nucleus where it damages the DNA of this cancer cell and causes cancer cell death. So this is a really unique drug because it binds to the CD123 very, very strongly. So it's really a good drug for a disease that has this CD123. And the particular payload, this chemotherapy it's linked to, is a novel payload that's very active in this disease. And so this is being investigated both as monotherapy, just as on its own, and in combination with other drugs that we already are familiar with. And then the other strategy that's being investigated is CAR T cells. And some of you might be familiar with this because we're using CAR T cell therapy more and more in many of our leukemias and lymphomas and multiple myeloma. And so again, people who are developing these treatments are using this CD123 on the surface of the BPDCN cells to generate T cell therapies where we give people immune cells that target that specific protein on the cancer cells and then go and kill those cancer cells. So some conclusions and remaining questions. This is a rare disease. It involves multiple organs. It's very challenging to diagnose and really requires specialty care to make the diagnosis and determine a treatment plan. The treatment does involve some targeted therapies, but chemotherapy and sometimes radiation are also integrated into treatment plans. Stem cell transplant remains a really important modality in all eligible patients. And as I've said multiple times, treatment at an experience center is very important. Patients who are eligible for clinical trials and who are in an area where a clinical trial is being performed should highly consider that. And then more therapies are being investigated every day. So it's an exciting field where hopefully we'll continue to make some strides. There are some remaining challenges. So this is a rare disease. There's no standard of care to treat it. It's very hard to conduct the big trials that we really prefer in order to determine what the optimal therapy is. So sometimes we're left relying on much smaller trials, but doing what we can to understand the best options for patients. It is challenging to make the diagnosis. It's also very challenging to treat those patients who don't respond to any therapy at the outset. And those patients who have what we call primary refractory disease can be really challenging to treat. And the high relapse rate that I mentioned is still a great challenge. So we need more therapies that we can give at the outset to give people the best chance to get into a remission and hopefully a durable remission. But we also need more treatments in the relapse setting for those patients who don't maintain their remission and need further therapies after their initial therapies and even after transplant. So I'd like to thank everybody on my team at Mount Sinai Hospital. I'd like to thank Cancer Grace. This has been a really exciting opportunity for me, and I hope that this was helpful for everybody listening. Mostly, I want to thank all of our patients and their families. You're the reason we do all of this, and please feel free to contact me if you ever need anything.